So the thrombectomy beyond 24 hours, it's been kind of an interesting topic to us for a while. It's one thing I've always felt, when you read the large trials, that it's just automatic that we go only up to 24 hours, obviously for a reason, because of the dawn and diffuse, most of the dawn that went that far out. So but we didn't have much data beyond that. However, with the advent of modern imaging modalities, I always thought that, if we can estimate the penumbra and the core, then why do we have to stop at 24 hours? So what we decided to do is to collect data that for patients that came into our hospital, and at some point the decision was made to proceed with thrombectomy, even though on paper they were outside the window, and it's always relative with whether they're witnessed or not, and how strict that 24 hours is, that we always take as a guideline. So, but in any case, we collected retrospectively from our database, for a prospectively maintained database. We collected all the patients who were treated beyond the 24 hours, and we found 39 patients. But the median age was 69, so which is pretty close to a pretty representative of a generalized stroke population, so a relatively older population. Half of them were females, and they had, we looked at the risk factors that they had, and they were very basically common risk factors that they had, certain percentage of smokers and hypertension and all that stuff. So, and then obviously we took the patients who had some larger cell occlusion, otherwise they wouldn't have gotten thrombectomy. So all these patients did get thrombectomy, so obviously had a larger cell occlusion. And they had, as far as the symptom severity goes, it's the median pre-procedural NIH stroke scale was in the early teens, so 11. So kind of both end of the spectrum, but but basically a typical, medium severity stroke population. And so we looked at the results, like how successful was the revascularization, how much, what was the ratio of good outcome, and as well as symptomatic intracranial hemorrhage, which is a measure of, obviously a bad, not complication necessarily, but something that safety for the results. And so those are the data that we looked at.
It seems to me, and you can correct me if I'm wrong, but there hasn't been such a consensus, I guess, per se. Do you feel as though that this sort of just, opens up the possibilities that more people should be accepting patients past this window? And also, to that same point, is there a time point in which we can't do too much necessarily past the 24 hours? Let's say, I don't know, 48 hours or things of that sorts?
So just as we presented this not so long before that, not a retrospective, but larger multi-center analysis was published. And so we found pretty similar results. So it's very encouraging overall, because what we found is that if you compare the good outcomes and the safety profile based on this retrospective data, it was pretty close to what we've seen in other, big trials that were within 24 hours. And again, we enrolled our patients based on those criteria. So we obviously, except for the time window, try to, stick with the core penumbra ratio, and they had to have the largest occlusion. So pretty similar, other than the time window. So the fact that we were able to see a pretty fairly similar numbers and good outcomes and a safety profile to those large trials, I think it's quite encouraging, and goes along with other data that is currently coming out from other centers as well. So I believe that it's important in convincing neurologists and other professionals to consider, not forgetting the time, but that's not true, but but try to take into consideration that you can have people who benefit from thrombectomy even after the conventional 24-hour window. Remember, TPA started with 3 hours, and then how far we've come. But I'm not promoting off-label use of anything here. That's not the point. But I certainly think that it's a good thought-provoking data set, confirming that it seems safe and efficacious. Again, probably we'll need more data to be more widespread before people modify their protocols and do this on a routine basis. But at least for now, I think this is very promising, and we always in our field, as you've seen the recent ISC results too, like we always try to see where we can expand our our patient population who could benefit from thrombectomy, and obviously SELECT2 and Angel aspect, and just at the recent ISC was able to achieve that. So this is another, I think, aspect that we certainly can do better and more for more patients.